Well, happy to be here. I'm Pedro Ramos. Yeah. I'm Pedro Ramos. I'm a physician, a researcher at a medical university called Karolinska Institute, and the CEO of this company here that is on this logo called Promptly Health. Well, thank you for the team at Newcastle NHS Trust for inviting us to present, especially to Wayne, to Mel, to Vicky. We have been whom we have been working with for the past year. We have been invited so many times in the past year to Newcastle that I'm considering buying some season tickets to St. James Park. No chance. You said that yesterday. No chance. But I still consider that you are rocking in the Champions now. So maybe that's a good. So uh, how can I move the slides? Hit that like this. Yeah, exactly. So it's always good to start a presentation by something that you don't truly believe. Like this sentence here. Patients are at the heart of the healthcare data universe, right? So if we were able to hand over the data of each patient to his smartphone or to something that he would be able to hold, I think that would be the actual perfect data universe. But the reality is, like was being said before, that the majority of the healthcare data still exists in the hospitals. Hospitals are the big holders of healthcare data. And I think it's fair to say that we in the hospital side always believe that our data is the best. We always say that we are sitting in a big pot of gold. This sentence is something that I've said in the hospital side many times, and we have heard many times from hospitals. But the truth is that when you look under the hood, the reality is that the vast amount of data that is usually in the EMRs, it's actually not activated. So in the majority of the use cases that you would want access to some data for real world evidence, like the previous panel that was mentioning that they would want to validate their technology. That data is actually not really readily accessible, and it is not by default being improved, being linked, and being checked against like some really basic data quality checks that you would be able to almost do in almost all variables, all clinical variables that you know. And I think it's recognizing, I wouldn't say this problem, but more this opportunity that in the past year we have been working with the Newcastle NHS Trust. In simple terms, what we are doing is we deployed a platform, a technology that we created that is local, is in their system, so it's not in our cloud. It's in their own premise. And what is actually doing is harmonizing this data. We always compare it to creating a library here at Newcastle, where we are like reading all the books. We have an AI agent that is reading all the books and it's cataloging every page to a specific subject that book actually has. I think that more than the technology, why technology is the last word and not the first, I think what this year has been proving is that really the challenge here is trust. Of course, we are a company, and the hospital is a public organization, and really the big part of this year has been and continues to be and will be on building this trust on the organizations, but also between the people, like having weekly meetings. Like we have weekly meetings to discuss opportunities, to, of course, monitor on the progress of the project. So really building these trustworthy relationships is the first part for us to start discussing how companies, like technology companies, small technology companies, and I would even say larger life science companies, can actually work together with the public sector. We hope this is a seed that with this trust we can also, let's say, borrow some trust that the Newcastle NHS Trust already has in the region for us to then go broader. Like think of there are other hospitals in the region that could benefit from a broader alliance, a broader use of data across multiple hospitals, link this data, and start thinking of the Northeast as like as really a powerhouse of the use of data, not only in the UK, but also for Europe and why not globally. Well, this slide, I think it's very obvious. When you are able to activate the data, and again, this depends on trust, then the opportunities are immense. We have been discussing a few of these with Newcastle team. We have several projects on the pipeline, several uses of data on the pipeline. Some are commercial, like will be discussed next, but some are also like public funding, like we discuss European research opportunities that we go together. Again, I think all comes back to like really using that and improving that gold, but having the trust to actually working together side by side. And the benefit for it is also how to improve finance, really use some of that or some of those assets to revert funding and revert revenue back to the hospitals. And we have a very clear model where all the uses of data that exist with data on Newcastle are used to then reinvest on the public sector. That can be with typical real world evidence projects that already exist, but take a more manual route. But it can also be with actually start curating some specific data sets to use for like drug development purposes. And why not? Like the future, of course, is on AI. Like one of the sessions before was this AI growth strategy for the Northeast. There are several opportunities emerging for AI factories in Europe. The term AI factory is really something that is growing in Europe, and of course, in the end, the actual fuel for building AI products is actually good curated data. And I really believe again that with the work that we are doing here in the Northeast with Newcastle, we can be really a node for good data that can be used in a secure, safe way for the benefit of patients, for improving innovation, like with new AI projects. We then, of course, have potential clients that can use this data. And I guess one of the examples that we have been working very closely is Novartis. We have been, fortunately, we and Novartis are strategic partners to, we and Newcastle are strategic partners to Novartis. So we are like finding ways for us to really build this trust and start working in a very trustworthy way. And maybe this opens the floor for you, Jonathan, to explain also your views on this.
Thank you, Pedro. I'm using my phone for my slide notes. I promise I'm not posting on Snapchat or Flapjack, as my daughter likes to call it. So my name is Jonathan. I'm the Medical Affairs Director for Novartis, and part of my role is overseeing real-world evidence generation and integrated evidence plans. So it gives me great pleasure to speak to you today about data partnerships alongside Pedro. Over the next few minutes, I'd like to speak a little bit about the real-world evidence from a pharmaceutical perspective. I'm going to be addressing some of the current challenges we have with data access. I'll then be giving an example of how we've managed to overcome some of those challenges. And then I'd like to conclude with where I see the future of data partnerships to access to optimize patient care. So real-world evidence is relied upon by the pharmaceutical industry to reinforce findings from clinical development programs in a less controlled real-world environment. But it requires access to trusted and reliable data sources. And with a healthcare system like the NHS, work is continually done to assess and evaluate healthcare decision-making and processes. And while these two approaches come at things from a slightly different angle, the goal is the same: to improve patient care and outcomes. And so what we look for are opportunities to collaborate and to work in partnership with healthcare systems. And doing so comes with numerous benefits, increased efficiency, shared resources, and the opportunity to scale, which is particularly valuable in areas such as rare diseases where the populations can be so small. Clearly, any data partnership project will require data sharing and access to external data sources. And at the moment, that comes with some significant challenges, and they can potentially really limit the impact of the value of the project. So timelines can be impacted by variable data update schedules, meaning that by the time the data is available, it's often out of date. And access to certain data sources can take a long time to plan and undertake potentially lengthy feasibility assessments. There are often issues with consistency of data structure, format, and quality, making it particularly challenging to link data sources. And any work on standardization, such as the OMOPS common data model, can be hampered by limited uptake. Building on the issue of data quality and consistency, coding inconsistencies and missing or incomplete data are significant factors that can potentially introduce bias into projects. And a lack of shared governance and ambiguities in terms of data ownership can affect contracting and usage rights. Before we even get to any of those points, there's the question of the fitness for purpose and lack of transparency around certain data sources. So what data is available and whether it will address the questions being asked or suit the ultimate use cases, such as regulatory environments. And finally, these projects require oversight of a multidisciplinary team, requiring significant resourcing with shared skills and knowledge. So those are challenges not necessarily unique to any specific disease area or research question, but when you go into certain subjects into more detail, further challenges can be unearthed, such as in the cardiovascular space, where alongside the data capture and the coding issues just mentioned, there are issues with a very fragmented data landscape, in particular in labs and pathology services. So with all these challenges, it's a wonder any data partnerships actually work or will get off the ground, but thankfully they do. And it's thanks in no small part to groups such as Newcastle, where this sort of work is not just supported, but encouraged. And in this particular example, there was a shared aim to address evidence gaps and evaluate strategies to improve adoption and standardization of lipid testing, to provide data that contributes to improvements in patient care. This slide provides a schematic of the project with each of the stakeholders in the data network project. So the NHS trusts provide anonymized patient data and worked in partnership with Promptly, the intermediary on data harmonization. And Pedro touched upon some of the points around data harmonization there, provided by Promptly, providing a secure data environment, working on the extraction, harmonization, and data analysis. And Novartis acted as the project initiator and sponsor, but also working to address evidence gaps, supporting PPI, so patient public involvement, and dissemination of findings, and engaging with stakeholders to guide the delivery of the project. And we also had representation from each of those groups in the steering committee to oversee the project delivery, all with the aim of improving patient outcomes. And so to conclude on where I see this go one step further, while we were really pleased to be able to contribute to the data network project to address one stage of a patient journey, and there are many other such examples, where we'd like to get to is a coordinated approach that tracks along the whole patient journey as shown here. We know that multiple data sources are available, and these can be loosely attributed to each stage of the patient journey, from population health screening with tools such as Our Future Health, onto the diagnosis of diseases with CPRD and potentially HES data, secure data environments and disease-specific registries, contributing data around treatment initiation and evaluation, and the audit cycle to continuously evaluate ongoing follow-up. However, to build on this would be to link these secure data sources using a federated model with a single point of entry, transparent and standardized processes and data formats. And as an industry, we welcome the government's proposal for HDRS and look forward to seeing how that will manifest. The potential wins of accelerated research, both in clinical trials and real-world evidence generation, supporting innovation and earlier access to medicines, and these will hopefully allow us to ultimately take a step forward towards optimizing patient care. Thank you very much for your attention.
So, Pedro, Jonathan, thank you very much indeed for that. I think that's just a really good exposition of where we are in terms of the whole issue of how we begin to use the data, the huge amounts of data that we have available to us most effectively to move things forward. I'm aware that I'm now between you and coffee. However, does anybody have any questions they would like to ask either Pedro or Jonathan? Yes.
How do you deal with the concept of data ownership, given that the data you're working with is patients? So how do you reassure the patient that their data is safe and secure and actually has permission to use it in the first place?
Pedro, do you want to? I don't mind. Whoever of you would prefer to take that one.
Yeah, so the patients are involved in patient committees for all the projects, and of course the data is de-identified, and even for the outputs, the data is totally anonymized. So it's actually aggregated data. So actually fully anonymized data in the concept of actually de facto anonymization. So the data that stays in Newcastle is de-identified, but the data that is used for the project is only for potential project that was mentioned is only anonymized data.
Yes, to just check with the concept. I mean, are those patients given their permission to use that data? Is it correct? Is it collected correctly? Because patients may not know the data has been used in these new processes. How is
Yeah.
So Pedro, do you want to comment, and then Wayne, who's sitting right behind you, I think will comment because he's done a lot of work on this.
Yes. So just a brief comment on that. So we are for the actual participation of the patient in the research process, we are using the same framework that the Data Saves Lives is using, that is involving patients in the governance committees for the use of data. So of course not all the patients that exist in Newcastle, but there are, let's say, champion patients that are included in these patient committees, and that is being done across the entire country. But maybe.
Yeah, Wayne, do you want to comment on that?
Yeah, and just to reinforce that, all patients have the opportunity to opt out as well through the national opt-out process. But furthermore, we didn't just rely on that. We've done a lot of public and patient engagement, and we've held sessions in the trust. And we've also, for one project, we've written to all of our patients. So that's 40,000 letters going out, informing them of these great research projects and the opportunity to feed back to us, to tell us how we can improve and do better. And also if they want to opt out. So we feel as though at every stage they have that choice in terms of being part of this great journey.
So I think this is an absolutely key area for us to get right, because if we don't, then we'll lose the confidence of the public and of our patients. And I think it is essential that we do that. I say that partly from a personal level and partly also because I happen to be the Trust Caldicott Guardian. So if we don't get it right, it's my fault. I think this is absolutely essential. Yeah.
Thank you for the talk. Such a critical area. I hear the word patients, but who are your controls? And how do you define a control population that really enables you to pull the power of a diagnostic set of information towards good therapies?
Mm-hmm. Well, maybe not going too deep, too fast down the rabbit hole, but depending of course, these are research studies. So each research study has its own methodology. The most common one for these real-world evidence studies is to create synthetic control arms. So you would, in a way, create a control arm that is synthetic with population with patient matching characteristics. Because these are not clinical trials, right? These are real-world evidence projects in, let's say, phase 4 type of projects. And the most traditional way to do it in clinical data is to use synthetic control arms, where you match the let's say intervention population with a synthetic matched population that does not receive the intervention. For projects that are not descriptive, because some part of this project, since the data is actually not accessible, like Novartis was saying, some of the initial aims are just purely descriptive in a way, and one of the advantages is being able to actually bring that descriptive nature faster, because in some ways, some of these initial descriptive nature can take 1 year, and 1 year just to get really treatment journeys and really more high-level descriptive views on the treatment journeys is too lengthy. So yeah, these two dimensions are maybe the right answer to your point.
Okay. One final question from Nick, and then we'll move on to coffee.
Nick Reynolds, I'm a PI of an NIHR data project called AI Multiply, and we've done a lot of work with patients. And I would reinforce that patients really want their data to be used. I think the complexity here may be around the commercial side, and I think that's really important to underscore and to make sure that everyone's aware of that. I think the other important thing which you did emphasize was the join up with primary care. And as you know, the region is working really hard to try and join secondary and primary care together, because it's clear from what we've been doing that people moving in and out of different systems and relying on one data source is not necessarily optimal.
Okay, thank you very much, Nick. Right, I think we should break there for coffee. Thank you very much, Pedro and Jonathan. Thank you.